Hi, I'm Colin Hung from Healthcare IT Today, and I'm really excited for this panel that we're about to start on a very important topic, patient engagement. What is healthcare getting right, and how can we do it better? We have a very diverse panel up here, so I'm very excited to get to it. For all of you guys assembled in the audience, please use the HIMSS19 hashtag so you can tweet it out and follow it online. And we're trying to get you guys involved as well and with some questions. All right, so let's just start here on my left. Go ahead and introduce yourselves, give us a quick brief overview of who you are, and we'll go down the line.
Thanks, Colin. Hi, this is Kelli Bravo. I'm the Vice President of Healthcare and Life Sciences at Pega. I'm super passionate about healthcare, have extended experiences at Microsoft, Pega, Centene, and I'm very happy to be here today. Thank you.
Looking forward to it.
Hi, I'm Carol Everhart. I'm a Director, Industry Principal for Healthcare, mainly on the provider side. I'm a nurse by background, spent 15 plus years at the bedside, kind of moved into healthcare IT, and now a caregiver for my elderly parents, so I kind of span the gamut of what patient experience really is.
Hi there, I'm Jen Horonjeff, founder and CEO of Savvy Cooperative, and I am a patient first and foremost, somebody who grew up with chronic illness, ended up coming into the healthcare space as a human factors engineer doing human-centered design and as an academic researcher studying patient-centered outcomes.
Great. Hi, I'm Shahid Shah, and I think I'm an optimistic curmudgeon.
Is that such a thing?
It might be. If not, I'm inventing it today. So I run a company called Netspective Media. We write and educate healthcare IT developers about the business of healthcare so that they make the right things.
Excellent. If you pass the mic down here. So the first question I have is for the Pega folks. You guys just recently did a survey that was pretty interesting around patient experience and patient engagement. Can you maybe talk to us about the survey and maybe some of the interesting results that you got from it?
Sure, I'd be happy to. So we surveyed with a third-party survey company 2,000 consumers of healthcare to better understand how they thought they were being treated, how patient engagement was working, how the organizations they interacted with, their doctors, their health systems, their insurance companies, were treating them. And then we also surveyed those organizations to see if there was any contrast in opinions.
Interesting.
So we will be able to share a little bit about kind of what was unique about the perspective of a consumer using care versus what the delivery people are thinking and how they're delivering care. Would you like me to share a little
Yeah,
bit?
for sure. So
Okay.
that sounds really cool. So you're saying that basically you pulled the people experiencing the care,
Yes.
then you pulled the people who were providing the care,
That's
and you were
right.
looking at the delta.
Exactly.
Okay, I want to know the results.
All right, so the most unique thing that I saw in our survey was that nearly 80% of consumers would actually switch doctors if they had a bad experience or bad communication from that doctor. But think about that. It's pretty unique in that when you think about the way healthcare used to be delivered, you did what the doctor said, right?
Right.
Everyone
Doctor was
followed.
always right.
Always
Doctor was
right.
right.
So the fact that today's consumer feels empowered to make a choice and actually act on that choice was a pretty big change from perspective, especially when you consider that only about 40% of the providers even thought that the patients would leave if a bad experience happened. So that's not very many. It's a pretty big
you said
delta.
80% of patients would leave
Yes.
if they had a bad experience, but on the other side, they only thought only 40% thought the patient would leave if they had a bad experience. That's a
Exactly.
big delta.
It's a big delta. So that's one really interesting thing. The other thing I saw that was kind of unique was that consumers are looking to engage across all different channels. So web, chat, phone, in person, and they're getting more comfortable with that. But they still want a personalized approach. When we asked them what is the number one way you want to talk to your doctor, more than 60% said on the phone.
On the phone.
But on the flip side, more than 50% said they'd be willing to do an online appointment. So they're starting to get there, but they're just not there yet, which makes me wonder, is it that the technology isn't ready? Are we not personal enough when we create that experience? Or what is the reason why they're experimenting with technology, but they're just not ready to go yet?
Carol, anything you want to add to that in terms of the results or the survey that was done?
Yeah, so I found some pieces interesting about what they were willing to share off of their mobile devices, off of information that's being collected. So 60% of consumers would give doctors real-time access to the information, but they would only give the insurers 37% were willing to share. So I thought that was interesting that, and I get the purpose in that, certainly they want their physician to understand metrics and components that they're collecting on their devices, but they're maybe not sure how an insurer would use that information.
Sure.
So I thought that was an interesting piece that, open in one end, but not open.
No, for certain audiences.
Yes.
Jen, I'm curious to get your opinion on some of these numbers that are being quoted. Is this surprising to you? Is this kind of like, no, this is kind of what you expected?
Well, I think it is and it isn't. It's interesting you talk about the 80% of patients or consumers, how we want to refer to them, as saying that they would switch.
Yes.
But the mechanics of actually switching, I think, is very different. Yes. Because they might say they want to switch, but yet sometimes they just get locked in because there's so many other barriers. So that's kind of what I'm hearing from it, that you're hearing the sentiment of the patient, but it doesn't necessarily mean that that's something that they even have access to be able to switch.
That's a good point. Shahid?
Yeah, so the curmudgeon part of me says that those numbers, while good, from a just a survey perspective, aren't actually true because the evidence doesn't show that they've left, to your point. So perhaps next year, you guys run this survey pretty regularly, and I'm an avid reader of them, so keep it going. But the question you could ask as a follow-up to that first one is, have you left a provider? Not just would you, but have you left? And that delta will be very telling, and it will be very telling in a variety of different ways. Geographically, in a heavy populated, competitive environment, say New York City, LA, et cetera, that number may be higher. Medium populated suburban areas, a little bit lower. At the rural and others, it'll be like near zero. They might say, I would love to switch, like at 99%, but have switch could be like 2%, right? And so now, the curmudgeon part of me. The optimist part of me says, one thing we could do is to perhaps reframe the idea of patient engagement to say patient support. Because engagement is something that we think of from our side. Like, we want our patients to be engaged, but who cares? They don't care about us. We care more about them because whether we make money on them or whether we care about them because we're conducting services. So what we need to do is to say, what is it about these engagement capabilities that we have, especially a leader like Pega has, that encourages better support of patients? That's what business we're all in, right? We're in patient services, patient support. And so when we reframe that and say, how do we use the engagement tools to support patients better, that might help us speak to patients a little bit better.
So I'm curious about that aspect of it. Patient engagement is very nebulous. It's a sort of a term that was splashed around a couple of hymns ago. It was on every booth in here. How would you define it, and can we define it in a way that's actually measurable?
So what we tried to do in the survey was to ask the patients or the consumers of health what it was that they needed to know. So the questions were very specific. Is it the communication was good? Was the experience good? Or were you getting multiple pieces of information that were inconsistent? So we tried to drill into that a little bit. So for me, patient engagement is our ability to connect with someone in a personalized approach, provide them the information they need when they need it, and make sure it's relevant to them for the experience that they're having. And so we tried to kind of unpack that a little bit.
Right.
And I think there are aspects of it that we're pretty good at measuring, like some NPS scores. You can measure the satisfaction. We know that if you increase satisfaction, you can increase overall experiences and revenues in some cases. But I'm not sure from a clinical experience, and maybe Carol can help me with this, if you can actually measure that part of engagement. What do you think?
What do you think, Carol?
So I think there's so many pieces that go into the patient's perspective of engagement and of their experience. And so what they're going to factor into that are some things that we, as the healthcare deliverers may not even take into consideration. The appearance of the chair, the approach of the person, we consider those items, but that's influencing their decisions on healthcare as well. That, their interactions that occur, the communication, is it two-way communication? Was I understood when I was relaying information to the physician or to the, anyone involved in the sector of healthcare? How many forms did I have to fill out? Did I have to fill out the same thing 5 times? That leads into their perception of what the patient experience is. And so using, better technologies to make some of this more seamless for the patient to get it right the first time so that they're not having to do a lot of that redundant work and providing that negative experience that they're going to walk away with that I didn't enjoy that at all.
So more friction free. I love it.
Yeah.
I love it. Jen?
What do you want me to comment on?
Hey,
here?
whatever
There's a
you
lot
want,
going
Jen.
on.
I love your comments.
Well, I think when it comes down to it, just speaking to what you're talking about, like the patient's going to make an assessment on, how is this going to go based on those different kind of touch points or what the environment is kind of like. And I think that then goes back to when we talk about patient engagement and how engaged a patient is, and you talk about whether or not the clinician feels that they're engaged, and the patient may want to be, but the way I think about it is that the whole ecosystem is set up in such a way that is not seamless for the patient. And therefore, if you know me, one of my least favorite terms is non-compliance.
Right.
Because it just puts the onus on the patient as if they don't want to follow their treatment plan. As if they're the ones that have gone off the rails, when truly it's because they don't have a ride to an appointment. Right. They are trying to get prior authorization. They can't cover things. And so there's just so many different places for friction that if we can get technology that does make it more seamless, that does make it integrate into their lives, then they can actually engage in their care. But we need to build out that infrastructure together, not in silos.
Not in silos. I love it. Shahid?
So when you think about the way that patient engagement tools are delivered these days, you've got the experts like Pega that are doing a great job there. What we're doing a horrible job on is understanding that patient engagement, patient support means different things at different points in time. So you have to say, for example, the pre-patient experience and engaging someone through your website, phone, et cetera, at the time when they're making a selection about what facility they should go see, what doctor they should choose, is quite different than the engagement one would have if you are physically present at the facility. We tend to think about patient engagement tooling as something being remote, but it's not. Once the person has arrived, now it's a retail experience. At that retail experience, what you do with engagement, telling them where to go, wayfinding, et cetera, those are all parts of patient engagement. Post appointment, now they've moved to the back. Now they're starting to get their service. Engagement there means something very, very simple. What the hell is going on? Where's the guy who's going to come see me? Where's the nurse that's coming in? So the view that tells me you're third in line, your nurse is going to be here in 30 minutes, these are all possible today. The tech is there. We're not thinking about it from an integration point of view. Now, post appearance, so you're now finished with the multiple visits that you did, and I'm talking about a very simple experience in an ambulatory setting. This gets much more complex in an acute care setting, right? So you have to think about these as slices. What's the flow happening? And then there are verticals in each one of those slices that tell you what the engagement should be. So now you're leaving, pre-discharge, you're getting instructions. Does anything show up on your phone, or do you get printouts? Post-discharge, you've just now left. Hey, how was your visit? Give me your survey, et cetera. You've now reached home within 24 hours. What did you engage? Within 48 to 72 hours, what did you engage? So this idea about patient engagement and patient support on an aggregate or macro is a useless discussion, which is exactly why you heard her say what she did, because it's not her job to think about that as a patient. It's our job to say, I've got the tech. I know I can put this all there, but what does that experience look like at every part of the experience, and which part is retail? Which part is behind the scenes? Which part is clinical where it matters most? Which part is non-clinical? And once we do a little bit of just that thinking, some of the problems that she just mentioned will automatically go away, because all we did was, the biggest problem in IT side, connecting to clinical, is attentiveness. How do we attend to what the patient and the provider need at that time to then connect the systems? 10 years ago, this was a different problem. Sure. We didn't have the tech.
We didn't have the
now
tech
it's
to do
an
it.
attentiveness problem. How do I get the tech to connect at the flow?
Jen, do you agree with what Shahid just said in terms of contextualizing the experience?
I do, but I think and this can be semantics, the fact that we're talking about it this way, but saying the patient engages at this point, and then they engage at this point. Patients don't necessarily know or need to know that we're saying you need to engage at this point. Okay. So even just talking about the language and how we talk about it at the bedside with the patient, it needs to be different than the way we're kind of talking about them. And so therefore really engaging with patients to kind of co-design what these solutions would need to look like, to sound like, et cetera. So it's happening in a way that's purposeful. And it makes me think of many of the various technologies that have come through Savvy to get patient perspective, and asking people to log their meds or things like this, that they're like, that's an extra step for me.
Right.
You know, taking the meds is one thing, and now you want me to, you know, get on my app every day. So, it just depends on what we're talking about here, and whether or not it's something, again, that like just integrates in their life, that they don't have to have another thing that they have to do.
And one quick note, and I couldn't agree with you more, and that's why that language of engagement versus support matters. They just need help, support, et cetera, at these various steps, and the tool might be the engagement tool, but really our objective is to support whatever is going on at particular points in time.
Carol, what are your thoughts on that?
Yeah, I just wanted to add to that you know that the engagement or the support component has to be the right type of component for that individual person. It really has to be personalized, because we're all at different levels in what we understand and how we can ingest that information and use it, you know, to be able to follow the treatment plan, and again, bringing back some of those components of, you know, patients don't want to be non-compliant. I totally agree with that, and I believe that there was a study several years ago that showed that only about 5% of patients are truly non-compliant. It's really the barriers that are in the way that we didn't address to meet that individual's needs and personalize, you know, that experience for them based on where they are economically or where they are socially or what their support system is around them, and being able to pull all those components together to provide them with, you know, the best outcomes that they can achieve individually.
Kelly?
Well, I was thinking a little bit more about what you were saying specifically, and I think that what we ask our clients to do is look at the patient's journey from the patient's perspective,
Yeah.
as opposed to saying, gee, I have this, you know, business I need to meet a need for, and I have this team I need to solve a problem for. The customer and the patient doesn't care about that. Let's follow the patient through their journey and understand what is happening at each stage and what can we do differently to both personalize the experience and yet deliver the best information. Like, what's the next best thing we should offer to that patient when I have them on the phone? If I know that there's another issue I can solve for them, why am I not solving it now? Why am I making them call me back a week from now when I can actually proactively get the information to them? And the more we think ahead, more proactively, the better the experience will be for the patient and the better the outcome, because they don't want to be non-compliant. It is a terrible word, right? It sounds, it's very critical. I think what we're trying to do is figure a better way to reach out to that patient ahead of time, be proactive, provide the capability or the knowledge or the path that they need so that they can continue to do their day-to-day life without having to worry about it. And the more we can think ahead and the more we can make it specific and personal to that patient, the better off the system will work.
Love it. So we want to remove friction. We want to remove the words non-compliance from healthcare.
Yeah.
Is there anything else that you think we can remove from the healthcare system or from the process of being, or anything from that patient journey that would make the overall patient experience better? So what can we remove? Shahid, go ahead.
I'm loath to do this to compare industries in this case, but what I want us to think about is the transition from in the airline industry when we used to go up to a teller to get our tickets and then do the check-in and wait in line, and then so one thing they ended up doing was making us do all the work, and we're happy with it, right? So that's called self-service. I think that's the key here is when you're thinking about the engagement or the support, what could you remove from the friction part of it, which is other humans that have to get involved? Could self-service, could the ability for the patient to initiate it on their own? And the reason why I was loath to do the airline analogy is they're in the news a lot for bad service, but in this case, think about the fact that if I don't like the online check-in, and I go in, stand in line, or I do it over the phone, I'm not non-compliant. Just means I prefer to do it on the phone. Why? Because, like for example, some senior executives spend a lot of time in their cars, and they would rather do something on the phone. Doesn't mean they're dumb. It doesn't mean that they don't know how to do digital. It means they don't want to crash their car and do digital. They want to do it on the phone. But if they're in a meeting and they're bored, then they're going to do it on digital. The omni-channel self-service model has worked in other industries, and it's a bad idea to make them equivalent, but just that concept of self-service that pulls people out that they don't have to be involved might be a way for us to move forward.
I was going to add to that, excuse me, just the concept of silos, right? If we could take away the silo between, oh, I'm the billing department, or I'm the clinical department, or I'm the registration department, and all really work together more collaboratively, we would create a better patient experience. Because again, at the end of the day, the patient doesn't care what group you're in, they just want to have a positive experience. And yet we organize ourselves in ways that make it difficult for that patient to just flow through. So between, I've picked a service, I'm coming in for care, I'm getting my bill, I just kind of want to flow through my day. I don't want to struggle with each department.
Right.
So that would be something I'd want to remove.
Carol?
Just tagging along with that, removing the barriers. There are just so many barriers in so many different places within the journey that occurs. So, I think kind of knocking down those walls and bringing back some of the human touch. We're still humans at the end of the day, and we want to feel heard and, that comfort, especially when we're experiencing a health issue or seeking health care for one reason or another. The humanness has to stay there. So removing those barriers and making it easier to receive the treatment and access the care that's needed.
So we've got removing people, we've got removing friction, we've got removing lots of things. What have you got, Jen? What would you remove?
I would say remove or don't make in the first place useless technologies or services or products that aren't solving real problems.
Okay.
And that, I think, when we look around events like this and there's a lot of people innovating, but are they purposeful? And is it actually making a meaningful impact in a patient's life, or is it more tech just for tech's sake? And so let's not just add extra things that aren't solving the problems that a patient has. And it goes to the fact of these are real people. Let's understand what else is going on in their life and what's most important to them. Because what's important to a clinician or to a technologist or a company could be very different than what's actually important to the person or the family that's going through that care journey.
I'm gonna put you on the spot. Do you have a specific example of a technology that's kind of like, why do we even have this?
Well, I'm not going to call out any particular companies or names, but yeah, I do think that there are certain things that are, like I say, some of these adherence apps are certainly some barriers. Some of the multiple logins for check-ins for things. I do think there are some wonderful technologies. I walked into my health system where they had finally integrated I can check in on my own. I mean, they had the whole palm print for a while, but now I can check in, and then I nerded out with the receptionist there. I'm like, is this making your workflow better? And this is great for me. Is it great for you? And I think that's important. It has to be a win-win for everybody for these things to actually be sustainable. But the more they can actually integrate, because, I'll say another sort of personal story that I think while there are technologies that are trying to get things easier for patients, if the system themselves doesn't accept it, it doesn't work. And so therefore, like as an example, getting my health records, I can get them all on my phone, but my clinician still wants a hard copy. So they won't even see that I already have access to all of them. So until we get all these players on the same page, a lot of this technology doesn't actually solve the problem that it's setting out to do.
Yeah, and so one thing that we can learn from what Pega has done is do the survey, ask the questions. That is a positive, a priori way of figuring out what the expectations are. But it's often untrue what people tell you versus how they act. That's a well-known behavioral science problem. So what we actually have to do is, and this technology does exist in most places, but it's sheer laziness on our part, whether it's an integrator or whether it's IT people, however you look at it, it's laziness on our part that we don't add telemetry to tell us what people are doing at particular times. And if you were to just add very simple analytics and reporting, not even some advanced machine learning and other things, just basic telemetry to tell you, customers tell me this, but they actually do that. That distance often is with the friction that we're creating, sometimes, or outright patients just don't tell us the truth, because people like to sound better or less abrasive when they think that we're expecting something from them, and that's okay. But the laziness that I think we have in the IT sector is that we ask, but we don't verify. We don't check the systems. We've already got them for a while. If this was 1999, asking is okay. In 2019, why are you asking them something that you are already making them go through? So in that case, 3 things you should do, like immediately. 1, what are the reports that you already have right out of the box, and are you looking at your patient flow, at least for inner office? 2, go into your PBX system and see how many inbound phone calls you have and how many outbound phone calls you have that lead to voicemails. Those are the 2 things that are causing friction. Like right now, no advanced technology, et cetera, necessary. So you take these basic reports and analytics from the PBX and your existing systems, and that helps you fix your local environment. What it doesn't tell you is, what are they going through on the friction, on the self-service that they could add? And the way that you do that is, don't look first at asking them, because they are accustomed to significant amounts of other industries, and they already have these behaviors where, like I said, I like the online check-in, you liked the online check-in at the hospital. Nice way of equating that. So you start to say, well, what are the behaviors that we see patients doing outside that they probably prefer, because we're doing it all over the place. If you can make the so often people complain, especially as a UI designer and a system, when I write an EHR, so I've written multiple EHRs, people tell me, your software is clunky. It doesn't really work well. It's not intuitive. All they're trying to say is, it didn't do what I expected. That's it. It's really nothing more advanced than that. And the way you can fix that is, just make it work the way that they think. Not the way you wanted it to, not the way that you think it should be, but what do they expect? And if they're on Facebook all day long, Facebook could have a horrible interface, but if you make it look like Facebook, they'll think it's great because they spend all day long on Facebook. These are the kind of things that we're not, and I'm complaining more to my IT brethren in that case, is we're lazy because we just take a little input, anecdote from here, I like this, I like that, etc., but 1,000 anecdotes do not make evidence. Get the evidence from the systems, be a little bit more aggressive on discipline, and things will start to improve pretty quickly.
So let's unpack that with some of the other panelists here. So Shahid was just talking about some technologies that we could bring to bear that actually can have an outsized positive impact on patient experience. Looking at telemetry, just looking at the friction points and doing what people expected. Are there any other technologies or any other things that you think if we just use that, we could have a real big positive impact on patient experience?
A couple of good ideas. So some of our more innovative clients are actually using a workforce tracker, using intelligence to identify what is the customer actually, or excuse me, what is the agent actually doing? Because you're right, people will tell you one thing because maybe they're embarrassed, they don't want to tell you exactly. So they say, no, I never have to cut and paste, or I never log into more than 2 systems, my day is so easy. Right. Nobody wants to complain. But then you find out that they're logging into 8 systems and they're cutting and pasting 100 times. So you can use robotics to do the cutting and pasting for you, little bots, right? They can do that. Now I have more time in my day. I'm a happier employee. I'm going to spend more time talking to you and a better frame of mind, which creates a better experience. You can also use this intelligence to figure out where you can automate things to make it easier for your agent to get their work done, which means, again, they'll have more time to spend with the patients. It's also true with the care team. If you can automate some of that workforce that they do in the background, making it easier for them. The other thing that we're finding really, really innovative clients are doing is they're using artificial intelligence to identify exactly the behaviors you talked about. So I may say I only want to get phone calls, but when the intelligence looks at how I react, I only ever look at my texts. For whatever reason, I didn't want to tell you that. So what happens with artificial intelligence is it can say, all right, Kelly likes to get texts. She might say she wants phone calls, but when I look at her and her behavior, exactly, I identify that I should be sending her text. And when I look at people like her, I can compare that maybe that is the best way. And so the system will learn and say, well, the next person that comes up and says phone, how does that person's profile look? Does it match to mine and everybody else's? Maybe we're going to try text. And if it works, they're going to update the profile for that person. If it doesn't work, the learning will figure out what's the next best opportunity for them. So those are a couple of things. And the third thing I would mention is that when we use our concept of next best action, I started to talk about that earlier. When a patient calls in or emails in or comes in through a chat bot for more help, you can identify what are the other things in their universe based on what they said in chat, based on the email they might have had, based on the last 5 phone calls, based on where they went on the website. What are they looking for? What problem are they trying to solve? And so you can use that intelligence to then serve up the next thing you think is most appropriate for them so that they don't have to come back. Maybe they were searching online for billing, but they called up about an appointment. maybe you could solve both of those problems at the same time.
So one of the things, just tagging onto that, based on what we're offering in the marketplace, is really that patient 360 view, bringing forward the most relevant information to the person that's first and foremost, on the phone, and the agent or the nurse or the whoever, the caregiver that's interacting, so that they have that most relevant information, because nobody likes to repeat the story 50 times. Right. They forget a piece of vital information, and then that gets lost in the translation. And so some key components of what that patient or consumer may need is left out of the picture because it wasn't first of mind at the moment, or they were distracted by something else. So I think that 360 view is really, really important. Not having to dig around through an EMR or a system to try to find this, the vital piece of information that's going to solve the problem at that interaction. So being positive and bringing forward what's needed at that moment.
And I really love hearing that, because, I think people are still human. We understand that you have to go and talk to multiple people. Like, we're not going to solve all of those problems. But if you can cut down on, like you say, the repeats, I don't think that, again, people are not being unreasonable if you say, I'm going to have to transfer you to somebody else. But if they can make sure that they don't have to go through the same sort of rigmarole, and you can cut that out, that definitely improves the patient experience. So I'm happy to hear that.
So Jen, what about, is there a technology though that you think, hey, if you just did that, not so much removing something like we talked about before, but in terms of a technology, you go, wow, those really are making a difference in terms of patient engagement, patient lives, patient experience?
No, I think there's a lot that's really helping to improve that if you can be able to message a care team, like you say, on whatever that is. Maybe you do want to call sometimes, but I love the fact that I can just message my doctor, because as somebody who's just trying to live my own life, it might not happen between 9 to 5 that I can have those conversations. So being able to do it on my time when it fits in, being able to schedule those same kinds of appointments, being able to get, prescriptions that automatically get refilled and reminders texted to my phone, all of that's been great. It cuts out a lot of that, running around, chasing down that person for the refill or whatever it might be. But, I think, again, until we get all the various systems to connect, that is the challenge, but it's been wonderful to have that in a way that can, let me put it this way, patients don't want to be patients. We're trying to just live our lives. Therefore, the more that we can support them to be able to go and live the life they want to do with their family, with their job, etc., that's really kind of what the end game is.
Yeah, and I think when you look at the tooling specifically, SMS literally is the digital health tool of the century. Okay. If you took away everything else, take away my mobile phone, etc., and you left me with a feature phone with SMS, that would still continue to drive a significant amount of benefit with the absence of everything else. Definitely it is the tool of the century. Now, why is it the tool of the century is what I'm also always interested in. My thesis is that it's about conversation. It's not about, so we make it a little bit more fancy around communication and engagement and things like that, but we just need to talk to people, because that's how, in the old days, we used to learn things. We just asked each other things. And one of the problems with phone is it's a non-scalable conversation mechanism. But it's a great vehicle. I'm not saying you should get away from phone. What SMS lets you do is scale conversations. So I can keep more people involved, and SMS, I'm not thinking of SMS as a short message service protocol. I'm thinking of it more as a global concept of text-based interactions. Right. But we have to realize that the message, and this is again about the expectation. If I got a message from you, and then I responded to you on that stream, you and I are friends, we have each other's phone numbers. I will know Colin said X, Shahid said Y. It comes in a little zigzag pattern. But remember that when you're chatting with a bot, what happens? There's a foreign number there. There's no personalization that it came from Julie at Dr. So-and-so's office. And then that becomes against my expectation. It will seem kludgy, it will seem clunky. And so we've got to figure out that if this is a conversation, what's the human on the other end? And just calling her Alexa doesn't make her human. I mean, but knowing that there are other humans on the other end, knowing that text-based is the literal tool, but it is the conversation that we want to know is continuous. So if they join the conversation on the second day, meaning like this happens with practices today, somebody sent me a message, I sent back, it got forwarded to somebody else, other people are joining the conversation. Well, how do you know who joined, who left, etc.? And we don't often care about that. Again, it's laziness on our side because we're not seeing that the conversation is the expectation. If that's the expectation, don't make something super advanced to take me to Mars, just make it look like I'm communicating with human beings whose name I might know. Like you remember in Atul Gawande's checklist manifesto, one of the stories that he tells is that the quality of a surgery or a group impact goes up just by introducing yourselves. Well, why is that? Right? He's got a nice chapter in the book that explains this, so it's good, worth reading. But it's because if it's not personal, you're not having conversations, then you are distant. And we don't want patients to feel they're distant. We want them to feel they're closer. And what's beautiful is that the nurses and the doctors are already pre-wired to be close. They're just lacking the tools to begin and continue these conversations over time. They're trained in medical school to have encounters. There's no such thing as an encounter anymore, right? You go in and come out, but then the conversation continues, and that's really hard. This is our challenge over the next 10 or 20 years, is embedding these technologies in an engaging way where it disappears. They don't even know that they're using these tools. They just know they're having a continuous conversation about things they care about while they're living their life.
So Shahid, we're getting to the end here, so I'm going to start with you and we'll work our way down in terms of, I want to revisit one of the statistics that you talked about. That gap between 40% on one side and 80% on the other side. How can we bridge that gap in terms of whether it's a technology, whether it's a process, whether it's just sort of an involvement of other parties? Give me your opinion on what we can do tomorrow to start reducing that gap between expectations.
So where this expectations gap occurs is because physicians are busy doing physician-y things, and nurses are busy doing nursing things, and patients are busy living their lives. So if we want to change this, the idea that you know what the patient was going through before they came in and what the physicians are going through with their daily life, the patient flow, if we were to solve that problem and do even simple things like wayfinding, if I know where to go, that is an expectation that I have. I can't even begin my encounter if I don't know how to end up where I'm going. The same thing is on the physician side. What room am I supposed to be in? Where is the package before she walks in that I have to be able to begin the conversation with her? So physicians believe that they already have all this information, it's just not being supplied to them. Patients know that they've already given the information, but it's not available. And it is our lack of telemetry that doesn't indicate to us that there is that big gap. So adding the telemetry to say, so ultimately all healthcare systems are simply information processing systems first. So how are you doing your information processing? Where's the input? At what stage are you at? Where's the output? So if you study it in those terms, now you can start to shrink that gap because the expectations on both sides start to match.
Jen?
Well, I always think, we have to first reflect on what are the needs of the different stakeholders. And that's the complicating thing about healthcare, is that there are so many unique different stakeholder groups. And so they all need to be pleased, all their needs need to be met in order for this to flow properly. And when it comes to patient care, it also means that I need the care team to have a good experience as well. Otherwise, it doesn't work for me. If my physician is still trying to figure out how to input things in their EMR and get the right code for my random thing that I came in with, then that's a bad experience for me, even though they're the ones that's interfacing with the actual technology. So if we can really make sure that we're thinking through everybody's needs and that it's matching the services that we're trying to provide them, then it all begins to work more in harmony. So that's what I'd like to see.
Awesome.
I would have to say the personalization. So really bringing that patient situation, their total situation into the picture and making it more realistic for them. It's not just an encounter, it's not just an appointment. It's a part of their life, and it needs to fit with all of the aspects. If they don't have food, it's going to be a bad day. If if they don't have any way to get to the appointment, it's going to be a canceled appointment. So bringing all of those factors together and personalizing for that patient what they need at that specific time.
Final word.
Final word. Well, there's nothing more personal than health. Right, so if we can personalize the experience in a better way, if we can proactively solve the problem that the patient is having, because when you're not feeling well, you don't want to have to fight and argue and debate your way through and ask so many questions. You want your problem to be solved. And if we can do it in context for what that individual is doing at that moment, we will create a better experience and ultimately deliver better care and better business outcomes as well.
I love it. Love it. This has been a fantastic panel, you guys. I love all the different opinions. I learned a lot. Thank you very much to Pega for hosting the discussion. Thank you to all of you again. Thank you to all of you for listening. It's been very fun. So this is Colin Hung with Healthcare IT Today. Thanks for joining us. Thanks for watching.